صبح خیر و خیلی متشکر از دکتر یغمایی و دکتر راد و بقیه organizers برای دعوت کردن من که باهاتون راجع به how to treat AML in 2021 صحبت بکنم. از این به بعد من با اجازه با انگلیسی حرف میزنم چون واسه من راحت تره که پرزنت بکنم.
اجازه بدین من شما رو اینترودیوس بکنم.
Okay.
Hello, good evening, ladies and gentlemen, dear colleagues. My name is Farhad. I am the assistant professor of hematology and medical oncology at Tehran University of Medical Science. I'm so honored to introduce this webinar entitled How I Treat Acute Myeloid Leukemia. In the last years, we see new drugs are coming and improve results in some particular subsets of AML. This is important that we update our knowledge about new drugs in this field. It is a great opportunity that we have Professor Ravandi here. Dr. Farhad Ravandi is a professor of medicine and chief of section of acute myeloid leukemia in the Department of Leukemia at the University of Texas and the Anderson Cancer Center. Dr. Ravandi is board certified in internal medicine, hematology, and medical oncology. His main areas of interest are therapy of acute myeloid leukemia, as well as other leukemia, including Philadelphia positive ALL, hairy cell leukemia, and T-cell leukemias. He's authored several book chapters and many articles in peer-reviewed journals. He is a member of several professional societies, including American Society of Hematology, American Society of Clinical Oncology, and Society of Hematological Oncology. And he is a member of editorial board of several journals. I'm asking the audience, please participate by writing your questions and comments in the chat box during the session. Unfortunately, we have Dr. Ravandi only for 60 minutes, so we collect the question and reschedule another session for question and answer. Dr. Ravandi, the microphone is yours.
Thanks very much. And again, thank you. And I'm very sorry that I have to leave after 1 hour because of an emergency. So when I talk about acute myeloid leukemia therapy, I always like to show this slide, which is from our institution you can see 30 years ago. Even then, we recognize that even if you give the same treatment to patients based on their cytogenetic abnormalities at diagnosis, you can have very different outcomes with different survival expectations. Of course, Dr. Greenwade in the UK had this largest study of their patients and looked at their outcome based on cytogenetics, and you can see that there is a very different outcome for the 3 lines at the top as opposed to the ones at the bottom, and they're all essentially treated with the same regimen of Ara-C and anthracycline. Of course, our understanding of the biology of AML has even gone further, and now we have recognized recurring mutations. This is from Dr. Papa Emmanuel in New England Journal, again showing in a large cohort of patients presence of recurring mutations, some of them being very relatively common, such as the FLT3 mutation or NPM1 mutation, others less common. So we have started developing specific drugs targeting these molecular aberrations in leukemic cells. But I think probably the most significant recent development has been the introduction of this agent, venetoclax, which is a BCL2 inhibitor, which, as you all know, was initially approved for treating CLL or chronic lymphocytic leukemia. But Dr. Konopleva in our institution did a phase 1 study based on preclinical data, or actually phase 2 study using the CLL dose in relapsed AML, and showed that there is activity only about 20%. But this led to combining venetoclax with hypermethylating agents. Now, I'm not going to go through the phase 2 studies, but this was tested in a very large randomized trial. You see the eligibility is patients over the age of 75 or younger patients who are unfit for chemotherapy because of organ dysfunction. And as you see here, 433 patients were randomized to either receive venetoclax plus azacitidine or placebo plus azacitidine. Again, these patients were deemed not fit or suitable for traditional chemotherapy. Now, of course, this has been a major development, and as you know, the combination of AZA plus ven produced over 66% response, as opposed to what we expected to see with AZA alone, which was about 28% all comers. And if you look at the complete response rate, AZA plus venetoclax is close to 40%, and the AZA placebo arm performed as well as we expected, which has been reported about 18%. And you see here the time to achieving response for AZA venetoclax is roughly about a month. So a lot of people, the median time, at least about a half of the patients achieve their response in the first cycle. But you know, there are patients who achieve it at later cycles. Of course, this is led to the approval of this strategy in the frontline setting of elderly unfit AML patients. And this is the overall survival curve from the same study. And you see the median overall survival for the AZA arm is what we had seen before, about 9 months. That's the AZA plus placebo arm, whereas the AZA plus venetoclax is close to 15 months, the median survival. And this is remarkable because you can look back in the literature, looking at studies of induction chemotherapy for older AML patients. And in those studies, they were fit older AML patients. That is, people who would be eligible to participate. And even in those studies in older AML patients, the median survival is only about 12 months typically. So in this very unfit older patients with comorbidities, median survival is 15 months. So clearly this shows that this should be the standard of care for at least the unfit, but perhaps the fit older AML patients because of its very low toxicity. There are other regimens that we have used in our institution before the introduction of venetoclax. This is one of them. This was quite a useful regimen, combination of cladribine plus low-dose cytarabine, alternating with decitabine. And the idea here is that you use different agents to try to overcome resistant mechanisms. And this was again in older unfit AML patients. And you can see in this study also the median survival is about 12 months, which is actually respectable in this population. And again, this is before the introduction of venetoclax. I can tell you that Dr. Kadia in our center is going to be presenting data of the same regimen when we combine all the agents with venetoclax. So cladribine, low-dose RC plus venetoclax, and decitabine plus venetoclax, and that will be presented in this year's ASH. Now we have started also adding venetoclax to the more intensive regimens. This is the FLAG-IDA regimen, originally developed at MD Anderson, but extensively used in Europe. Very intensive chemotherapy regimen. RC dose, as you see here, is higher RC than your standard 3+7. There is fludarabine and there is idarubicin. And the venetoclax is added, I would say it's in this study for 2 weeks, but I would advise you to do it for about a week because this is a very intensive myelosuppressive regimen. You see here in the newly diagnosed cohort in this study, we've had a remarkable thing that we've never seen before. Essentially, everyone is alive and doing well. But I would again tell you that this is a very intensive regimen. It can cause severe myelosuppression. You have to really watch your patients. I would highly recommend you hospitalize your patients for the entire month and be very aggressive with any fever or infectious process. Now we have a similar regimen called CLEA plus venetoclax, and that's cladribine, cytarabine, and idarubicin plus venetoclax. Here, venetoclax is 7 days, And again, you can see that it's very intensive with a higher dose of cytarabine, 1500 milligram per meter squared for 5 days. And in this regimen, also, we are seeing remarkable long-term survival for the frontline patients. Again, very intensive. In both of these regimens, many of the patients go on to have an allogeneic stem cell transplant because it's actually difficult to give multiple cycles of this regimen to patients. And again, even the consolidation courses that are lower in intensity, and you see here in the consolidation less number of days of agents. Despite that, the patients can get very myelosuppressed, and you have to be very careful and do this very carefully. What about adding other agents to chemotherapy in the frontline setting? And everybody knows about this study, the Ratify trial that was reported by Richard Stone, where they combined the 3+7 with or without midostaurin in patients with FLT3 mutated AML. So the patient had to be initially evaluated and found to have a FLT3 mutation. And they had to screen about 2,000 patients to eventually randomize about 700 patients. This was a mammoth Herculean study that took a long time, but at the end of it, it did show that the addition of midostaurin to 3+7 in these younger AML patients, the patients had to be less than 60, did produce significant improvement in survival, and this was seen across the molecular subsets that they looked at. So if you have a FLT3 mutation, nowadays midostaurin in addition to chemotherapy is standard in Europe and US. I would personally tell you that in my opinion, midostaurin is not the best FLT3 inhibitor. We were using on clinical trial basis sorafenib for a long time. And as you see here, when we looked at our combination of cytarabine plus idarubicin plus sorafenib retrospectively, this wasn't a randomized trial, but in a retrospective analysis, there is a significant improvement in survival and relapse-free survival when we used sorafenib, which is also a FLT3 inhibitor. Now, you know that we now have better FLT3 inhibitors. At least some of them are FDA approved. This one, quizartinib, our center, our department has been working to develop it for almost 2 decades. Unfortunately, for various reasons, this drug has not been approved. This drug was evaluated in a randomized setting in relapsed AML. So patients could get either quizartinib, which is an oral daily agent, versus salvage chemotherapy, that the things that you're all familiar with, MEC or FLAG-IDA, etc. And as you see here, quizartinib performed better, and it actually did even improve survival, but for a number of reasons, the FDA did not approve it. Gilteritinib is another very potent FLT3 inhibitor, and this is another randomized trial in relapsed FLT3 mutated AML. Gilteritinib has the advantage over quizartinib because it's active not only against FLT3 ITD, but also FLT3 tyrosine kinase domain mutations. Quizartinib is not active against FLT3 TKD. So in this study, again, gilteritinib was compared to traditional chemotherapy in FLT3 mutated AML patients in relapse. This is a salvage study as well, but here you see there was a significant difference and improvement in survival, and this led to the approval of gilteritinib for salvage therapy in FLT3 mutated AML. Now, groups have started adding gilteritinib to the frontline treatment. We have done that as well, and one of the things we are doing now is actually adding gilteritinib to the azacitidine venetoclax regimen in elderly AML. Also, we have done it with quizartinib, and you see here with such a triplet regimen, we are getting really remarkable outcomes. This was a retrospective look. Nicholas Short in my department will be presenting at ASH data on frontline therapy with aza, venetoclax, and gilteritinib in older unfit AML. Now, IDH inhibitors have also been approved in the US based on relapse studies. Enasidenib is for IDH2 mutated AML. And here, this was a study that compared azacitidine plus or minus enasidenib in IDH2 mutated AML. Unfortunately, this did not lead to a survival advantage. The event-free survival was significantly better. Now, many people believe that the reason why there is no survival benefit is because of crossover, as in patients who were on AZA alone arm, once they progressed, they were put on enasidenib, and that's why you're not getting a survival benefit. But also, we have started doing a triplet with the IDH mutated AML. So AZA, venetoclax, and ivosidenib. And this study has been ongoing in our center. Remember, these are all rare subsets of AML. So these studies take a bit of time to accrue. This was one of the early reports of this study. You see in relapse and refractory AML, 8 patients. In the secondary AML, 5 patients, and de novo treatment naive AML, 3 patients. But your responses are quite remarkable, and many of these responses are being very durable. So this could be a future of therapy, at least for IDH mutated AML. Now, there's a subset of AML that we all know is very difficult to treat, and that's secondary AML as well as therapy-related AML. Now, this is data from the Danish registry that was published a few years ago in JCO, looking at the outcomes of their patients in Denmark based on whether they had de novo AML, secondary AML, after a history of myelodysplastic syndrome, secondary AML with other diseases, particularly myeloproliferative neoplasms, that's the red line, and then therapy-related AML. And as you see here, the outcomes of these patients are significantly worse than the de novo AML, but particularly the therapy-related is very bad, as even worse than the others. Of course, there is a molecular signature for these secondary AMLs that's a bit different from the de novo frontline AML. So this is these diseases can be thought of as being biologically distinct, and this is data from Dana-Farber looking at the molecular signature depending on whether the patient had secondary or de novo AML. And one mutation that is obviously of a lot of interest to everyone is TP53 mutations. As you all know, this has been a sort of a problem in cancer therapy for a long time. We have always used chemotherapy in cancer therapy, and as you all imagine, P53 mutated cancers are not sensitive or highly sensitive to chemotherapy effects. And that's why it has always been a difficult problem. And in therapy-related AML, many of these patients have the TP53 mutation, and that this could be the reason why therapy-related or secondary AML, which tend to have complex cytogenetics and TP53 mutation, have worse outcomes. There may be hope in the horizon. There is a lot of interest in this checkpoint inhibitor. I'm not showing you any slides, but as you know, there has been interest in checkpoint inhibitors in solid tumor malignancies particularly, but also some interest in leukemias. And there have been studies looking at checkpoint inhibitors to see if you can reactivate the immune system against the malignancy and try to improve outcomes. Now in leukemia, various checkpoint inhibitors have been tried, and none of them have shown dramatic success. The interest in this agent, which is now a number of these agents, but the original one is magrolimab, is that CD47 is a molecule expressed on the surface of cells, such as tumor cells or leukemic cells, that it's a don't eat me signal, as in it tells or prohibits macrophages from breaking up and eating the tumor cell. And the idea is by blocking this marker, you can activate macrophages and improve the killing of the tumor cells. And there have been studies looking at CD47 expression in AML showing that there is a worsening of outcome in terms of survival. But there are now a number of CD47 in, monoclonal antibodies that block the checkpoint. As I mentioned, the first one is magrolimab. This drug is being evaluated, and I'm expecting to hear more about it in this year's ASH. Early studies showed it to be active in MDS, but also in untreated AML. You see here the degree of blast reduction on the right in the bone marrow of patients who received azacitidine plus magrolimab. And on the left side of the slide, you see the first-line therapy in AML in 25 patients. There was an overall response rate of 64%, which is significantly better than what you see with azacitidine alone. But we will have to see what the study shows. If it does pan out that this is a very active drug, it will be a strong addition, mainly because it's a monoclonal antibody. It doesn't have a lot of toxicity and can be added to potentially any regimen. And I always tell people it's like rituximab in lymphoid malignancies. As a single agent, it had very limited activity, but when you added it to various regimens, you improved outcomes significantly. Now, the main side effects of magrolimab, is anemia, because when you give magrolimab, it really results in macrophages removing all the senescent or older red cells in the body. So initially, you need to support these patients with transfusion. So if you're in a situation where you cannot transfuse the patient, this drug perhaps is not a good idea. Now, the reason there's a lot of interest in this is in this subpopulation of AML, that's patients with TP53 mutated. Again, in this report is only a small number of patients, only 12 patients. But again, you see the overall response in TP53 mutated AML is 75%, including 42% CR. As with azacitidine alone, you're not likely to get this much response. But again, small studies, so we will have to wait for the final results of the ongoing randomized trials to see if this truly is a useful agent and can be a major addition to our armamentarium in AML therapy. Another area that is of particular interest to me and has been for a long time, this is measurable residual disease in AML. Now, we did this study now about more than 10 years ago, where we were looking at the usefulness of decitabine as a maintenance therapy in AML. So in this study, patients who were in remission or CR or CRI were randomized to receive either decitabine or whatever the physician felt was appropriate, just continuation of chemotherapy or just supportive care, etc., conventional care. And at the beginning of the study, we did multi-parameter flow cytometry looking for MRD. So again, all these patients at the study entry were in remission. And we didn't see, it was a small study, it was only about 50 patients. So we didn't see an advantage for decitabine in maintenance, basically because it was a small number of patients. But we did see that if you were MRD positive by flow, you had a very, very worse event-free and overall survival. Again, it really emphasized my interest in MRD because clearly shows that if you have MRD by flow or by other tests, you're going to do worse. This has also been shown by other groups. This is the MRD study from Sylvie Freeman in the UK. The thing that you should look at this, the only thing I want you to look at is that if you're in CR and MRD positive, that's the yellow line, your outcome is only as good as patients who are in PR. And this is at the end of induction. So the people who are in CR and MRD negative, the blue line, clearly do better. But if you're CR, MRD positive, you only do as good as PR. So again, showing that a persistence of MRD at the time of CR is important and is associated with a higher likelihood of failure. We did this study in our group. We used a more intensive regimen of higher dose cytarabine plus idarubicin. There were a number of patients. These are all typically younger than 60-year-old patients because it's a very intensive regimen. And we looked at presence of MRD by flow at the time of achieving remission, during consolidation, and at the end of the consolidation. The left two slides are at the end of achieving remission. The middle two are during consolidation, and the right two slides are at the end of consolidation, at the end of therapy. You see at all these time points when if patients were MRD positive by flow, the red lines, they had a significantly worse relapse-free and overall survival. Again, demonstrating the importance of MRD. We've also done this in low intensity regimens. This is looking at our data. This is retrospective. Looking at patients who received hypomethylating agent alone. So this is just with either azacitidine or decitabine. You see on the right, if you were MRD positive at any time when you achieved remission, you are much more likely to relapse. So the persistence of MRD was associated with higher cumulative incidence of relapse. On the left side of the slide, unfortunately, this does not translate to survival or relapse-free survival, mainly because HMAs, either decitabine or azacitidine, are not highly effective agents on their own. However, when we looked at this, when we looked at our patients who were treated with hypomethylating agent plus venetoclax, this time decitabine plus venetoclax, you see that your MRD negativity is very much dependent on the molecular signature of the patient's leukemia. So for example, NPM1 mutated patients, we had 100% response, which is what has been reported, and 79% MRD negativity at the time of achieving response at CR, CRI, or MLFS. FLT3, high response, but MRD negativity is significantly lower. You see TP53, 64% response, and only 26% MRD negativity. So achieving MRD negativity is a function of both the disease biology as well as the therapy. Now, with the addition of venetoclax to the decitabine, we are getting much higher CR and CRIs, which is again dependent on the biology, and also the MRD status also dependent on biology. And if you look at patients who achieved MRD negativity at any time, the outcome, overall survival with this decitabine plus venetoclax regimen is significantly better, highly statistically significant. So MRD negativity should be a goal of any therapy, in my opinion. So here at 2 months, if the patients who were MRD CR and MRD negative, again, did significantly better than the ones who were MRD positive. Now, we can also assess MRD by different techniques or different assays. I'm sure all of you are familiar with this paper from the Dutch Hoven Group that was published in New England Journal of Medicine. What they looked at in this study is looking at mutation clearance. So they look at the mutation profile of the patients at the diagnosis, and then they looked at the clearance at the time of achieving a CR or response. And they showed that when you put away the CHIP mutations, that's DNMT3A, TET2, and ASXL1, excluding those mutations, if you had persistence of other mutations at the time of remission, this was highly statistically significant association on multivariate analysis with a higher likelihood of relapse and worse relapse-free survival. So you can use mutation clearance as an MRD assay. In this study, they had a really interesting group of about, I think, 350 patients where they had both MRD data by flow, MFC, as well as by NGS clearance. And you see that these two assays are complementary. So if you have only one of the assays positive and the other negative, the relapse rate is about 50%. If you have both of them negative, your relapse rate is only 25%, whereas if both of them are positive, your relapse rate is 75%. So essentially, it shows that we can start using and combining these assays to look at MRD. Now, myself and Nick Short in our group have published this paper in JAMA Oncology last year, where we did a meta-analysis of outcomes of patients reported in studies that looked at MRD in AML. And clearly, we showed that achieving MRD negativity by any assay in AML is highly associated with an improved overall survival and with improved disease-free survival. Again, establishing that MRD is an important predictor of relapse in AML, and in my opinion, achieving MRD negativity should be the goal of all therapy in AML. What about how are we going to achieve MRD negativity? Now, of course, traditionally, the best strategy has been allogeneic stem cell transplant in first remission. So, of course, everybody believes that in at least subsets, majority of subsets of AML, if you have a good donor, the patient is young and fit and can tolerate it, an allogeneic stem cell transplant can improve outcomes. This study from Roland Walter in Fred Hutchinson Cancer Center was very instructive. They looked at all the patients with AML who were in remission and were referred for an allogeneic stem cell transplant. And they looked by flow for presence of MRD at the time of remission. And they did show that being MRD negative by flow, the dark black line at the top is associated with a significantly better survival and better relapse-free survival on panel B. And this was really mainly due to the fact that these patients who were MRD negative were much less likely to relapse. That's panel C, but it wasn't really affecting the non-relapse mortality. That's panel D. So MRD negativity is really leading to a much lower likelihood of relapse, and this is translating to a better survival outcome. Now, the other importance of the study is you see there are these three lines, and these are MRD positivity at various levels, less than 0.1%, 0.1 to 1%, or greater than 1%. And they did show that no matter the level, you did have a bad outcome if you are MRD positive. So achieving a complete MRD negativity at the lowest level possible is probably the best way to achieve a better outcome. And obviously, this is, in my opinion, is obvious. And if you don't detect any leukemia by any assay, you're likely to do better. What about the choice of allogeneic stem cell transplant? Non-myeloablative versus or reduced intensity conditioning versus myeloablative conditioning. This is from Chris Horrigan at the NIH, and he essentially showed that if you are MRD positive and had a myeloablative conditioning regimen, you did better than if you received a reduced intensity conditioning regimen. And this was really mainly due to an increased risk of relapse with the reduced intensity conditioning regimen. So if you have a young patient and who's fit, who is MRD positive, and you're going to take them to transplant, you should use a myeloablative conditioning regimen rather than reduced intensity conditioning regimen to reduce the risk of relapse and improve survival. What about, sorry, another area of AML that has been very exciting and a new development, and that's the role of maintenance therapy. I mentioned to you that we did a study with decitabine alone many years ago in only 50 patients in our center, and we didn't show a benefit for decitabine. But this is the largest ever conducted study in maintenance in AML. It's over 400 patients, multi-center study. Patients who were enrolled in the study had to be over the age of 55 and had to have achieved a complete remission or CRI with intensive chemotherapy, so Ara-C and anthracycline-based induction. They could have received one or no or more consolidation. So, you know, you have had, I'm sure, these patients who receive 3+7, develop complications, go to ICU, recover, and then you don't want to give them chemotherapy. That's the sort of patient who would have no consolidation. But the patients could also enter if they had received consolidation. They had to have either de novo or secondary AML and a reasonable performance status, and they could not have a favorable risk cytogenetics. And they had to be randomized within 4 months of achieving CR or CRI. So that means they could have had consolidation courses. And they were stratified by various features that you see here: age, MDS, prior MDS or CMML, cytogenetics, or consolidation, yes or no. And they either received CC486, which is an oral formulation of azacitidine. It is not an equivalent dosing azacitidine. Please never do that. Never just get the patient to take CC486 instead of azacitidine, instead of IV azacitidine. This is an oral formulation that has a different pharmacokinetic profile. And it was given for 14 days versus placebo for 14 days. Now, patients were monitored very closely every 3 months, a bone marrow. If they had evidence of early relapse, you could actually increase the number of days of CC486 in the next cycle to 21 days. If they were really relapsed, more than 15% blast, they would be coming off the study. And again, this was a very well-conducted study, and they did do bone marrows and look for MRD by flow throughout the course of the treatment. They followed these patients, and the study lasted several years. In fact, many people had sort of forgotten about this study. And as you see here, this was a positive study. The patients who were randomized to CC486 achieved a significant improvement in their survival by about 10 months over the placebo group, with a hazard ratio of 0.69. So this is relapse-free survival, again, highly significantly an advantage for the CC486 arm, with about 5-month difference. And this is a recent report that's looking at by baseline flow cytometry MRD status. And you see that the benefit was there for MRD negative, but particularly there for MRD positive patients. So the MRD negative patients did benefit from CC486, but the people who did really benefit were the MRD positive patients. And this was also true in terms of relapse-free survival, significant advantage for both groups in terms of anyone who had CC486, because this was more pronounced in MRD positive patients as opposed to MRD negative. And MRD conversion occurred in 37 patients on oral azacitidine or CC486 versus 19%. Now, you may say, well, how did the placebo arm group have MRD conversion? And that's something we see. You know, you do a bone marrow, and then 3 months later, you repeat the bone marrow, and the MRD has gone away. But obviously, the people who were on oral azacitidine had almost twice as much likelihood of clearing their MRD, and this did translate to improve MRD negative duration. There are other drugs that are being evaluated for maintenance therapy. Sorafenib, as you all know, as I mentioned earlier, is a good FLT3 inhibitor. This German study looked at patients with FLT3 ITD positive AML, and it has to be ITD because sorafenib does not have activity against FLT3 TKD. But they randomized patients with FLT3 ITD AML who had undergone an allogeneic stem cell transplant in first CR. After the transplant, about 30 days onwards, they randomized them to receive either sorafenib or placebo. And you see there's about 80 patients on this study. And you see here that there was a significant improvement, survival benefit for the patients who received sorafenib maintenance as opposed to placebo. The sorafenib was continued for 24 months or 2 years. And that's where the line is here. And you see that, at least in my eyes, at 2 years, the curves start getting closer to each other. So we did this before this study. We used to put all the FLT3 ITD patients on sorafenib post-transplant. And I usually advise patients to take it indefinitely if that is a feasible choice. A similar study that I'm not showing here was also reported by the Chinese group in the Lancet Oncology, very similar post-transplant FLT3 ITD, sorafenib versus placebo, and they did show a significant benefit in terms of relapse-free and overall survival. That was a larger study from China. What about other ways of eradicating MRD? There is hope that we will develop a drug like blinatumomab for AML. You all know blinatumomab is a bispecific antibody that is approved in ALL. There is a lot of interest in developing these bispecific antibodies against either CD33 or CD123 or other AML antigens, and a number of them have been in development, and the studies are ongoing. Now, another area that is, I think, is very important is development of oral hypermethylating agents. Dr. Garcia Manero in our group has really led this. He has persisted over years with the studies that looked at an oral decitabine. This is a decitabine plus azacitidine, which is a molecule that inhibits the enzyme in the gut that breaks down decitabine. And essentially what they showed that this oral agent, oral decitabine, which I call Aztec 727, is equivalent in terms of its pharmacokinetics, in terms of its demethylating capability to IV decitabine. So this drug has been approved in MDS in the US. And our group is conducting a number of studies combining it with, for example, venetoclax to develop an oral regimen for AML. And I think I'm putting this slide here because I think this is probably our goal in all subsets of AML. This is APL. This is data from our center looking at our long-term outcome of APL patients treated with ATRA plus arsenic trioxide. We are developing an oral arsenic trioxide, and hopefully soon we will have an oral regimen of ATRA and oral arsenic trioxide in APL. But this is where we are going. With this non-chemotherapy regimen, we are able to produce long-term cure, highly effective strategy. Initially, we have been looking at MRD assessment, for example, in APL, but now we're becoming less and less interested in MRD in APL, mainly because we don't get any relapses. So I think the future of AML is going to be hopefully oral targeted agents in combination, MRD monitoring initially until we develop such regimens that you really completely eradicate the disease right from beginning, and then you really don't need to monitor the MRD. With that, I am very happy to answer your questions. And again, I apologize that I have to leave at 1 hour time. So we hope we can answer some of the questions at least.
Thank you, Professor Ravandi. Thanks for your very informative lecture. We have 50 minutes for the questions. I ask you the first question. What's your recommendation if the MRD is positive after first consolidation regime in favorable risk AML, like CBF mutation type?
Yeah, I mean, that's the question that can have a 1-hour presentation on its own.
Yeah.
So the ELMR Group, which I'm a member of, will be publishing soon their recommendations for MRD. I mean, I talked a lot about MRD, but you have to remember that MRD is only useful if you have a good assay and someone who can evaluate it. For example, flow MRD, you really have to have an expert flow cytometrist to quite convincingly tell you that this patient has MRD or not. But so there are all different levels of MRD, and this is particularly true in CBF leukemias because, as you know, there are at least in 821 translocation, but also perhaps in inversion 16, there are patients who can have very low level of MRD positivity for a long time and not relapse. However, if you do have a persistent MRD, both in inversion 16 and 821, at high levels at the end of induction, you are definitely more likely to relapse. There's no question about that. Of course, with the addition of gemtuzumab ozogamicin in the treatment of these patients, we see that less and less frequent. But if you are still positive, of course, you will continue with the consolidation therapy. And if you remain positive at the end of consolidation, you really definitely need to consider transplant. Or if you don't have a transplant option, you should consider clinical trials. So for example, in our group, we have a trial of azacitidine plus venetoclax in maintenance. And that's something that we may consider putting the patient on.
Thank you. Another question from Dr. Peka. Is there any role for gilteritinib in post-allo-HSCT FLT3 positive AML relapse?
There's definitely a role in relapse that's been what's been approved. I personally don't ever use gilteritinib single agent as monotherapy. I always combine it with something else. So for example, we have a study that has been reported in ASH and EHA combining gilteritinib with venetoclax. Now that can be very myelosuppressive, so you have to have a plan of action. But we also have in the past used gilteritinib plus HMAs like decitabine or azacitidine. Or if you have a very resistant relapse, we have used triplet regimen that I mentioned to you. That's azacitidine plus venetoclax plus gilteritinib. So the answer to the question is yes, definitely a role for gilteritinib. There are a number of factors. Is the patient potentially eligible for a second transplant? I can tell you I've had patients we've done this and I've gone on to the second transplant and are doing extremely well. So yes, gilteritinib is useful in the post-transplant relapse.
Second question from Dr. Peka. He writes, in our country that we have no access to target therapy. Are you agree to add cladribine to 7+3 induction regimen in young fit patient? And I change it to that unfavorable risk young patient.
Yeah, you know, there was the Polish study that was published in JCO a few years ago and did show that addition of cladribine is definitely associated with a better relapse-free and overall survival. So yes, I would definitely add cladribine based on the Polish study.
Yes. Another question from Dr. Q. Marcy. What's your recommendation for post-HSCT relapse in patients who are not FLT3 positive?
Post-HSCT relapse, not FLT3 positive. Well, you know, unfortunately, salvage regimens and, you know, it's very, in my center, life is a bit easier because we have multiple clinical trials. I mean, this is a situation where we offer patient phase 1 studies. So for example, our bispecific antibodies that I told you, we have used those in this setting in patients. Really, especially if it is after the second relapse transplant, or after relapse, if transplant was after relapse, there's very limited option available, unless you have a targeted agent.
I have a question. Is there any chance to treat a patient with favorable risk AML, like core binding factor mutation in CR2 and MRD negative without transplantation?
Sorry, favorable risk?
Yes, favorable risk in CR2 and MRD negative. Is there any chance to treat this patient without transplantation? Like,
I mean, the standard of care is if you're in CR2, you really need to consider transplant. If you don't have that option and you don't want to do that, this is why we're developing this AZA plus venetoclax maintenance strategy. I would favor doing that, AZA plus venetoclax maintenance. Because unfortunately, these patients are likely to relapse.
Yeah.
And you may ask me, how long maintenance? I would tell you I don't know the answer, but I would do it indefinitely if the patient has the financial means and the willingness.
Cytogenetic and molecular studies are available only in Tehran and some other big cities. So in or alternative transplantation committee, we faced cases that completed induction and consolidation regimen and then sent for allogenic HSCT. What's your recommendation in this type of cases that complete the treatment and we don't know the risk of the disease?
Yeah, I think if you don't know the risk and if you have a good donor and you have the ability to transplant, the patient is fit, I would transplant.
You prefer to transplant?
If you have no data, if the patient is fit, if you have an excellent donor, and the patient doesn't have active infection or whatever.
If the patient doesn't have a full match donor, what's your recommendation?
Do
you consider HOPLO?
That's unfortunately makes your life very difficult. Because then you just have to guess. And I do this with my patients. I talk to them and give them the risks of one way and the risk of the other way, and try to explain to them as much as possible the risks, benefits of each strategy, the strategy of non-transplanting and strategy of transplant. And the patient, sometimes, a lot of times, they make their own decision.
Okay. We have another question from Dr. Rashidi. He asked that we have a limited access to quantitative molecular PCR for evaluation MRD. Can we use WT1 in bone marrow and MRD evaluation?
Yeah, I mean, there've been a couple of studies on the WT1 expression. The consensus is that's not probably the best MRD assay. It is, if you don't have anything better, you can use it, but the ELN consensus is probably not the best MRD assay.
Another question from Dr. Peikar. Is there any treatment necessary for leukocytosis with developing gradual maturation during induction treatment of APL?
Okay, so that's obviously a situation that is a little bit debated. Our group was the one who developed this regimen of ATRA plus arsenic. And initially, in the first couple of years, we would only give, start the arsenic on day 10. And then you would have a rise in the white count. And later, we started arsenic from day 1 together with ATRA. And in the early days, we saw patients whose white count went very high, and 1 or 2 patients who developed major complications. That's when we decided that we need to suppress that. And so we use either a dose of gemtuzumab or zigomycin if the white count rises above 10, or a dose of idarubicin if you don't have the gemtuzumab. We use either a 6 milligram per meter squared of idarubicin. You do not want to let the white count go up very high because that's associated with complications such as differentiation syndrome and other complications. So the Lococo study that was published in New England Journal, they use hydroxyurea when the white count rises. The reason why we prefer gemtuzumab or idarubicin is because both of those drugs, gemtuzumab and idarubicin, are very active anti-APL drugs, as in they're not just cosmetic reduction of the white count, but they're actually effective. They're known highly active anti-APL agents. Hydroxyurea is really cosmetic. It just lowers the white count. So I would say yes, if there is a leukocytosis during the course of APL, you do need to reduce it. We use gemtuzumab or a small dose of idarubicin. The Lococo study uses hydroxyurea.
Yeah, thank you. What's your treatment choices during COVID-19 outbreak in AML?
During COVID-19?
Yeah.
I think you need to treat AML as you treat. If you're a young 30-year-old, you can't just, I don't know what the situation is in Tehran, but it's pretty bad in US as well, although, we probably have a lot more people vaccinated. But you cannot, I would tell you, I've had very few AML or ALL patients over the last, in fact, I can't recall any patients who have developed COVID. And that's because, in my opinion, and I don't have any data to support it, it's because these patients generally tend to be a lot more careful. They don't do anything. They already know that they are immunocompromised. They don't go out. You know what I mean? So they're less likely, and their relatives are a lot more considerate towards them. So I would say that you need to treat, because your best chance to cure AML is your first chance. So you cannot just give half measures hoping that COVID will go away. And the other thing is COVID may stay with us for years to come. So you really need to treat the patient as appropriate. Now, if you have an 80-year-old patient, AZA plus venetoclax is the appropriate regimen. But if you have a 30-year-old, you can't just give them gentle treatment. And I don't have COVID. You can't give them gentle treatment and hope that it will go away until you need to continue with effective therapy. And again, your best time to cure AML is your first chance.
Thank you. We finished the time of 60 minutes. I'm sure that the audience have many questions. We have your promise that we reschedule another session for question and answer. And we finish the program at this time. I hope that your problems solved immediately.
Thank you very much, and all the best and good luck.
Good luck. Thank you. Dr. Yakma, you want to say? Okay.
Thank you, Dr. Ravandi. Hope to see you very soon. Thank you for your nice lecture. I think that all the people got a very informative lecture from you. Thank you very much.
Goodbye.